Imagine waking up tomorrow and discovering your biological clock didn't just speed up, but it completely shattered.
Oh, man.
Right. Like overnight, you didn't age gradually. A fundamental systemic shift in how your biology operates just happened while you were sleeping.
Yeah.
You went to bed as one version of yourself and woke up in an entirely different physiological reality. Welcome to the deep dive.
It's just such a jarring concept to even wrap your mind around, that kind of abrupt physiological remaking.
Oh, absolutely.
But for a very specific group of patients who are navigating the aftermath of severe illness, this isn't, it's not a thought experiment. It's a daily physical reality for them.
Exactly. And today, we are pulling apart a stack of sources that honestly fundamentally changed how I view this major medical event.
Same here.
We're looking at clinical guidelines from Body Logic ND, the Menopause Consortium, and Women's Health Concern. But alongside that hard medical data, we have this incredibly moving academic thesis analyzing real patient experiences, plus some qualitative psychological studies from palliative care.
Which really grounds the medical data in reality.
It really does. So our mission for this deep dive is to isolate the profound psychological shockwaves of sudden treatment-induced menopause. And we want to explore why it creates like a completely different psychological universe compared to the gradual natural menopausal transition.
Yeah, and that distinction between the two experiences, the natural versus the induced, is really the only way to understand the landscape of this data.
Right.
I mean, obviously the medical reality of treating a disease is the priority, but the psychological aftermath of that treatment is just this vast, often uncharted territory for the patients living it.
Okay, let's unpack this.
Okay.
Because I feel like we need a clear way to visualize the underlying biology to even begin to understand the psychological fallout.
For sure.
So natural menopause is kind of akin to turning down a dimmer switch on a light in your dining room. It takes time.
Right, like 5 to 10 years.
Exactly. Usually between the ages of 45 and 55, the light just slowly fades. Your body and your brain have time to adjust to the dimming room. But treatment-induced menopause, whether that's triggered by chemotherapy, pelvic radiation, or surgical removal of the ovaries, it is not a dimmer switch. It is someone walking over and ripping the power cord straight out of the wall.
That is a great way to put it. And what's fascinating here is the sheer velocity of that biological change.
That's why.
The source data shows that with a surgical menopause, a patient experiences an immediate, sudden 100% drop in ovarian estrogen.
Wow. 100%.
100%. It just vanishes overnight. And concurrently, there is a 50% decrease in overall testosterone production because, well, the ovaries are actually responsible for half of the body's testosterone.
I mean, a 50% drop in testosterone overnight, coupled with a total loss of ovarian estrogen, that is literally a biological earthquake.
It really is.
In a natural transition, your body systems have a decade to slowly acclimatize to those decreasing levels. But when the patient undergoes chemo or surgery, they bypass that acclimatization entirely. The brain and the body are given absolutely zero time to adapt to this new hormonal baseline.
And that lack of an adjustment period, that is the biological root cause of the severe psychological impacts we see in the data.
Makes sense.
Because the central nervous system relies heavily on estrogen as a neuromodulator. So when you remove it instantly, the resulting instability goes way beyond, typical hormonal fluctuations.
It's systemic.
Exactly. It manifests as a profound existential distress. And that academic thesis we reviewed captures this dissociation perfectly with a quote from a younger cancer patient.
Oh, I remember this quote.
Yeah, she described the aftermath of her treatment as feeling like a 55-year-old woman in a 36-year-old body.
It's just devastating. Imagine being in your 30s, navigating severe hot flushes, night sweats, and these profound physical changes, while your same-age peers are in a completely different life stage.
Yeah, a totally different world.
Your friend group is attending baby showers, they're planning pregnancies, and the isolation described in these sources is just staggering. You're completely out of sync with the chronological timeline of everyone around you.
And that specific form of isolation triggers a psychological phenomenon that psychotherapist Julia Samuel refers to as living losses.
Living losses. I thought that concept was so powerful.
It really is. Because this sudden transition isn't just a change, it's a profound, active grieving process. These women are grieving the loss of what the literature calls the fertile self and the sexual self.
Right.
And the loss of the sexual self is particularly devastating because the sudden absence of estrogen causes rapid vaginal atrophy, which is the physical thinning and drying of tissues.
Which is incredibly painful.
Intensely painful, making physical intimacy almost impossible. So a woman is suddenly dealing with a body that feels entirely alien, and it actively rejects previous forms of connection. It's a mourning for a version of their life and their body that was just erased without warning.
You know, while reading the qualitative studies from palliative care, I actually found myself genuinely struggling to reconcile something regarding all this grief.
Oh, what was that?
Well, a lot of the literature initially frames this distress around losing fertility, right? Like the physical inability to have children.
Right, that's the common assumption.
But wait, when you read the actual transcripts of these patients, the despair seems so much larger than just family planning. It reads like a complete collapse of identity, even for women who already had kids or never wanted them to begin with.
Yeah.
So what is actually driving that massive level of distress?
That is a great catch, and the palliative care study actually deconstructs that exact assumption. The data shows the distress is not purely about the desire for motherhood at all.
Okay.
It's actually a much broader existential crisis. When researchers surveyed gynecologic cancer survivors who experienced this sudden infertility, 75% of them reported a profound sense of meaninglessness.
Wait, 75%.
75%. And 40% reported a total lack of purpose in their lives.
Feeling a total lack of purpose. That really elevates the conversation from just, disappointment over family planning to a complete crisis of identity.
Exactly. The researchers define it as a shattered vision of their future. Because human beings build cognitive schemas, right? Like mental maps of who we are, what our trajectory looks like, our roles in society.
Right, the story we tell ourselves about our lives.
Precisely. And when treatments suddenly strip away these biological markers of womanhood and youth, those foundational mental maps are just destroyed. The patient is left without a compass.
Wow.
The result is an incredibly high rate of clinical depression and anxiety that far, far exceeds the baseline of the natural menopause transition. It is a total destabilization of the self.
And that complete destabilization of identity takes an incredible amount of emotional energy. But looking at the clinical data, the exhaustion isn't just emotional, is it?
No, not at all.
It's deeply neurological. The brain is quite literally struggling to function. Like, in the sources from Percy Health, a patient named Farah provided this vivid description of her cognitive toll.
Oh, the marshmallow quote.
Yes. She referred to her severe brain fog as having marshmallows for brains.
The phrase sounds lighthearted, but, the reality she describes is just debilitating.
Completely.
She noted that work tasks that normally took her a single week were suddenly dragging out for 3 weeks. She would be halfway through a sentence and completely lose her train of thought, just staring blankly.
Yeah.
Managing a career or a household becomes a monumental struggle when your executive function is compromised to that degree.
We really have to look at the underlying mechanism to understand why this cognitive failure happens. It's not just the result of feeling tired, right? The abrupt hormonal surges and drops, that sudden power cut to the estrogen supply, act like a fire alarm on the brain's neurology. It specifically activates the brain's threat system.
Exactly, because estrogen is heavily involved in modulating the nervous system and regulating neurotransmitters like serotonin.
Okay.
So when estrogen levels plummet overnight, the brain's threat detection center, the amygdala, loses its primary modulator. It essentially goes into a state of hypervigilance.
Like it's stuck in overdrive.
Yes. The amygdala constantly scans the environment for danger, and it often hijacks the prefrontal cortex, which is the part of the brain responsible for logic and reasoning.
Oh, what?
So this causes the brain to react to completely benign stimuli as if they are life-threatening events. It triggers a chronic state of fight, flight, or freeze.
Here's where it gets really interesting, especially when we look at how this neurological shift impacts relationships. The nUnlike Health Survey pulled some staggering statistics on this specific dynamic.
Yeah, the relationship data is tough to read.
It really is. They surveyed women going through severe menopause transitions, and 73% of them blamed menopause for the breakdown of their marriage.
73%.
And 67% reported it increased domestic arguments, which makes total sense if the brain is stuck in a hypervigilant fight-or-flight state, right? The smallest interaction can be catastrophic.
Oh, absolutely.
An innocent wave from a partner or a casual question about dinner is intercepted by the amygdala, misinterpreted as a harsh criticism or a physical attack, and the body reacts with explosive anger or intense weeping.
If we connect this to the bigger picture, we have to consider the environmental context compounding this neurological state.
Right, because it's not happening in a vacuum.
Exactly. These patients are not just navigating the loss of a neuromodulator, they are simultaneously recovering from the profound physical and emotional trauma of surviving cancer.
Hmm.
They're coping with lingering severe fatigue from months of chemotherapy or radiation. Furthermore, they are suffering from chronic sleep deprivation because intense night sweats continually pull them out of REM sleep.
It's just a cascade of stressors.
It is. The combination of cancer trauma, chemical fatigue, severe sleep deprivation, and an unmodulated amygdala on overdrive creates a perfect storm for absolute psychological overwhelm.
So what does this all mean for the healthcare side of the equation? Because with an impact this severe and systemic, you would assume the medical system has a robust framework for managing it.
You would hope so, yeah.
Like, if an oncologist knows a treatment protocol will induce this sudden menopause, preparing the patient for the psychological fallout should be standard practice.
Unfortunately, the data paints a pretty troubling picture regarding that assumption. The academic thesis analyzing patient experiences highlights a tragic recurring theme across almost all the interviews.
Which was?
Women feeling totally blindsided, just thoroughly unprepared for the reality of their post-treatment lives.
I was reading through those patient transcripts, and the level of disconnect is genuinely difficult to process. One patient described spending 3 years thinking she was literally going insane. She assumed she was just failing to cope with the trauma of the cancer, to the point where she sought out a psychologist.
Just heartbreaking.
It wasn't until 3 years after her treatment ended that a medical professional finally informed her that she wasn't losing her mind. She was experiencing severe menopause. 3 years of enduring a neurological crisis without a diagnosis.
And that specific anecdote really highlights a systemic prioritization issue that the academic thesis explicitly details regarding oncological care.
How so?
Well, oncologists are highly specialized, right? And their
Hmm.
primary overwhelming focus is cancer survival. Their objective is to eradicate the disease and save the patient's life.
Which makes sense.
It does. However, within that intense, singular focus on survival, the debilitating quality of life issues like the severe pain of vaginal atrophy, the cognitive dysfunction, the psychological grief of sudden infertility, those are frequently minimized or bypassed entirely.
So the patient is essentially told, hey, we eradicated the tumor. The treatment was a success, while they are simultaneously left silently drowning in the side effects.
Exactly. The patients in the thesis reported feeling precisely that way. They described their post-treatment reality as an experience of avoidable pain endured.
Avoidable pain endured.
Yeah. The medical framework often treats the survival of the patient as the finish line of the journey. But for the patient, surviving the cancer is just the chaotic beginning of a completely new, incredibly difficult physical and psychological reality.
Right.
Because the systemic focus remains on the remission of the disease, these women are frequently left to navigate this profound biological remaking entirely alone.
Which leads to a massive clinical dilemma. Because for the general population experiencing severe menopausal symptoms, the established highly effective treatment is hormone replacement therapy, or HRT.
Right, HRT.
It addresses the root cause.
Mm-hmm.
But for many of these cancer survivors, particularly those who battled hormone receptor-positive breast cancers, HRT is strictly off limits.
Badly contraindicated.
Reintroducing estrogen into their bodies could literally feed microscopic dormant cancer cells and trigger a recurrence. So the biological fix is basically locked away from the people who arguably need it most.
This raises an important question regarding clinical intervention. If the biological pathway is blocked, if the hormones absolutely cannot be replaced, how do we alter the patient's experience of the symptoms?
Right. How do you fix it without the hormones?
The focus of the treatment has to shift from replacing the hormone to managing the nervous system's reaction to its absence.
And the sources point very clearly to one highly effective evidence-based intervention here: cognitive behavioral therapy, or CBT.
Yes. The clinical evidence provided by the Menopause Consortium and Women's Health Concern regarding CBT is really robust. It is a clinically proven, empowering alternative for women who are barred from utilizing HRT.
But to understand its efficacy, we have to look at the mechanics of what CBT actually does in the context of physiological symptoms, right?
Exactly.
Because it is important to clarify that CBT does not magically lower the body's core temperature. I mean, the data indicates that 65 to 85% of breast cancer survivors experience hot flushes, and talking to a therapist doesn't turn off the physical heat.
No, the physical flush will still occur. What CBT alters is the cognitive appraisal of the flush.
Okay.
It rewires how the brain interprets and subsequently reacts to the physical sensation of the rising heat.
Let's break down the mechanics of a hot flush using the examples from the sources,
Yeah.
because this is really practical.
Let's do it.
Imagine a patient sitting in a crowded meeting and a severe hot flush hits. The natural panic-induced reaction, what the psychological literature calls catastrophizing, is to immediately think, everyone is looking at me, I'm visibly sweating, I look terrible, I cannot cope with this happening right now.
And that specific catastrophizing thought process is not just an emotional reaction, it has immediate physiological consequences. Yes. That panic triggers the exact threat system we discussed earlier. The brain perceives a social and physical threat, which signals the adrenal glands to release a massive spike of adrenaline.
Oh, okay.
And that adrenaline increases the heart rate and dilates blood vessels, which physically makes the hot flush burn hotter and last significantly longer. The cognitive panic literally fuels the physical symptom.
That is wild. So through CBT, the patient basically trains the brain to interrupt that loop and adopt calm acceptance.
Exactly.
When the heat starts to rise instead of panic, the trained cognitive response becomes, this will pass soon. I have managed this physical sensation before. It is just a hot flush. It is not a threat.
And by neutralizing the perceived threat, the brain does not signal the release of adrenaline. Furthermore, CBT pairs this cognitive shift with specific behavioral strategies, primarily paced breathing.
Right, the breathing exercises.
And engaging in slow, deep breathing from the diaphragm stimulates the vagus nerve. This directly activates the parasympathetic nervous system, which is the body's natural rest and digest mechanism. By intentionally changing the thought pattern and regulating the breath, the patient physically prevents the escalation of the flush and completely eliminates the subsequent anxiety spiral.
So the patient is really reclaiming control over a nervous system that feels entirely unpredictable to them. Instead of being held hostage by the physiological symptom, they actually have a tangible, proven toolkit to manage the severity of the experience.
And the benefits of that reclaimed agency cascade into every aspect of their recovery. The clinical data shows that utilizing these CBT techniques improves sleep architecture, reduces the severity of clinical depression, and lowers the reactivity that causes domestic arguments.
Wow.
It returns a profound sense of empowerment to women who had their biological autonomy completely stripped away by cancer and sudden menopause.
So synthesizing this entire landscape, the reality of sudden treatment-induced menopause is just fundamentally different from natural aging. It is not a slow, gradual dimmer switch.
Not at all.
It is a biological power cut. That sudden lack of estrogen triggers profound existential grief over the loss of the fertile and sexual self. It alters the neurology of the brain, trapping the threat system in a state of hypervigilance.
Yeah.
And because the standard medical framework often minimizes these quality of life impacts in the pursuit of survival, patients require immense psychological resilience. They need specialized evidence-based tools like CBT to navigate the aftermath.
It really is a total remaking of identity, executed under the most extreme physiological circumstances imaginable. Empathy for this experience absolutely requires an understanding of that profound context.
Yes, and understanding this psychological remaking and realizing it is not simply, a few hot flashes, is the absolute key to offering genuine empathy.
Exactly.
Whether you ever experience this yourself, whether you support a partner navigating this transition, or if you simply know a friend recovering from cancer treatment, you cannot effectively support someone if you don't understand the mechanics of the invisible battle they're fighting.
Acknowledging the scale of the transition is really the first step in bridging that isolation.
Definitely. And we want to leave you with one final thought to mull over, extending beyond the clinical data. Society places an immense, often unfair value on youth, on fertility, and on a very specific type of physical womanhood.
Just so.
When cancer treatments strip those biological markers away overnight, it forces these patients into a painful, premature confrontation with those societal constructs. They're forced to face the biological power cut head-on.
Yeah.
But does surviving this sudden, devastating living loss ultimately forge a stronger, more profound understanding of what it means to be a woman? One that is forged in the fire of absolute survival and exists entirely independent of biology. The power cord might be cut, but perhaps the true psychological victory is learning how to generate your own light,